So thank you all for taking the time to be with us. I'm Mike Papale. I am the manager of community relations here at the FitTech. And today we have a interesting topic. Before we get into it, I just want to kind of talk about two quick housekeeping things. If you go to the bottom of your screen, there's a Q&A box for you where you can ask some questions. If you have a question, you can throw it into that box, and we will address the questions at the end. The other thing is if you want to share this information with anybody, we are recording it and we will be posting it to our YouTube channel. So that link will be getting sent out to you shortly after this webinar. So today's topic, and like I said, I think it's really important, being someone that was diagnosed with heart disease at a relatively younger age, is heart disease in children, what every parent should know. And we have a really, really special guest who, I've gotten to know really well and worked really closely with in the last few years, Dr. Cheyenne Beach, who's the director of Pediatric Electrophysiology at Yale New Haven Children's Hospital. So, Dr. Beach, thank you for taking the time to be with us today.
Sure, happy to do it. Thanks for inviting me, Mike.
Yeah, so I was thinking about the first time you and I met this morning, and it was funny timing because I think at the time we were living in the same town or one town away from each other, but we actually met down in Miami. So we had to travel down to Florida to meet. But so first I just want to kind of talk about what you do, and kind of, can you just kind of tell us a little bit about exactly what an electrophysiologist does?
Sure. So I'm primarily a pediatric cardiologist by training. So I trained in general pediatrics and then pediatric cardiology. But then I decided that I wanted to specialize in heart rhythm disorders, in children specifically. So I did additional training in pediatric electrophysiology. And electrophysiology is the diagnosis and the management of heart rhythm disorders. So I do that in pediatric patients and also in adults with congenital heart disease. So adults who are born with structural abnormalities of the heart requiring some intervention over the years. So I see patients in clinic. I help take care of the children and the adults with congenital heart disease in the hospital who are having abnormalities with their heart rhythm. And then I also do procedures for both of those patient populations.
Cool. And it's funny. I guess I'm very aware of the work you do now because but a lot of patients, and I guess you could tell me, do a lot of patients kind of have like, for a medical team, for someone that has heart disease, is it a combination of like you as an electrophysiologist along with seeing a cardiologist as well? Is that kind of how care kind of goes for patients?
Yeah, I really like that question. So it's a little bit unusual for people to get to me directly. Often people go through seeing a general pediatric cardiology first, and then they're identified as having an abnormality with their heart rhythm. I do see patients primarily in clinic who have a high index of suspicion for a heart rhythm problem. So I do see patients who have palpitations or racing heartbeats or episodes of passing out that seem like they might be heart rhythm related. But you're right that a lot of the patients that I see both a general pediatric cardiologist or somebody who specializes in structural heart disease, and they see me. Though if it's determined that really the only problem they have with their heart is electrical, then you only need to see me or one of my heart rhythm partners.
Okay, cool. That makes sense. So something that is still frustrating for me, as just being involved in this work, is that I think still as a society, we are looking at heart disease as it's strictly an adult issue or strictly an unhealthy person issue. So just really quickly, can you just talk about the prevalence of heart disease in kids? Because we know heart disease affects people of all ages.
Yeah, and I'll take a little aside here. You're absolutely right, Mike. And I think that you have worked very hard to try to make sure that it's known that this is not just an adult thing. A lot of people are surprised. So I'll meet a family for the first time in clinic, and they'll say, this was unbelievable that this came up in my often a very healthy, active, sometimes athletic child who comes in to see me in clinic. But you're absolutely right that there's a reason that my specialty exists, because this is something that comes up fairly commonly, actually. So A statistic that's used all the time is that congenital heart disease, or a structural abnormality of the heart, is present in about 1% of births. So this is actually a pretty sizable portion of the population. About a quarter of those, so a quarter of that 1%, have something called critical congenital heart disease, which by definition means that they need an intervention within the first year of life. Sometimes that's a surgery, sometimes that's a catheterization procedure. And then the remainder are often mild types of congenital heart disease, things like small holes in the heart that are going to close on their own and don't end up needing any intervention ever. But that's 1% of the population affected by some type of structural heart disease. And then we've got a few other categories of heart disease. So my category is primarily electrical heart disease. And there are a bunch of types of electrical heart disease that are heritable, or these are genetic conditions that are either passed down from a biological parent, or are created when a child is born with a new genetic mutation. These new genetic mutations are happening all the time. And these are thought to be, I had to write this down because I wanted to make sure that I had these numbers exactly right. So all in all, it's about 0.1% of the population who's affected by one of these genetic electrical heart conditions, which we'll talk about in a little bit, but they present differently from the little holes in the heart, from the valve defects that come up in the heart. And then there's another category of what we call cardiomyopathies that I know you are familiar with. So these are heart muscle disorders. These are things that often are also inherited, but don't present until a little bit later in life. And so you could see a baby who has a perfectly normal cardiac evaluation and then still has a tendency to develop a cardiomyopathy, or again, a heart muscle disorder later in life. These are things that can cause thickening of the heart muscle, dilation of the heart muscle, generation of fibrosis or scar in the heart muscle over time. And those numbers are relatively small compared to others. This is about 0.001% of the population who have these cardiomyopathies during childhood, with larger numbers that present during adulthood. And then the final category of heart disease that we see in children is acquired heart disease. So these are things like infections. In the recent COVID years, I think many of us have heard the term myocarditis, which is an infection or inflammation of the heart muscle. And these are things that can create arrhythmias that are not very often, thankfully, but they can be dangerous. And they also can create some cardiomyopathy, so some heart muscle that's not functioning totally correctly. And that's about I wrote this one down too, 0.001% of the population per year who has myocarditis. So all in all, we're looking at somewhere in the 1 to 1.5%, 2% of the population who ends up having some kind of cardiac condition during childhood years, which, there are many, many children in this world that are very special. And so that turns out to be a good number of we're seeing.
Yeah, definitely. I was actually at an event for congenital heart disease in kids, and I remember, I don't remember the exact numbers, so I don't even want to say anything, but I remember looking up the amount of babies that are born per day in the United States alone, and it's a very, very large number. So that kind of puts it into perspective when you kind of like think about those percentages. But so just kind of so I know you and I have talked at times where you're in a situation where you might not be comfortable sending a newborn home right away, and I'm just kind of curious the process of how that they get to you, right? There's a lot of babies that are born at Yale every single day. And, I guess how do you, or how does someone discover that you need to take a look at them and evaluate them?
Yeah. There are a few different ways that happens. The first is if we know that a biological parent has a genetic mutation that can be passed on to a child, then we have we're sort of winning the game if we know that we need to look for it. So we'll do some initial investigation. It depends very much on what the type of disease is. But a simple, we'll talk more about these, a simple ECG or electrocardiogram is often done in those situations.
Yeah.
Sometimes we send genetic testing right away. If we know a mutation we're looking for that we know has caused disease in a biological parent, then we can send testing. We can even send it from cord blood from the delivery room to get that answer, even within a couple weeks. So we know if that person is affected by the disease or susceptible to the disease. Other than that, it depends on the type of disease that we're talking about. So structural heart diseases are now, thanks to great technology that we have, usually detected in fetal life. So often we'll know babies who are affected by this that are being born, and we're in really great shape to anticipate the problem and take care of them appropriately. And that's true of structural heart disease, like I mentioned, but also the electrical stuff. Heart rates are, my lights go out sometimes in this room. Heart rates are monitored for people who've had babies before, been pregnant before. Heart rates are monitored. If there are concerns, you're monitored a little bit more closely, and you can even have a fetal cardiology appointment for a more detailed evaluation of what's going on. So thankfully, nowadays, we often have a good heads up about babies who may be affected by this. And then physical exam, so babies are listened to several times a day in the beginning. So if a new murmur is heard, if an irregular heartbeat is heard, then additional testing can be performed. And that could include an ECG, like we talked about, or an echocardiogram, which is a heart ultrasound.
Yep.
If we have concern for a heart rhythm abnormality, we'll often transfer babies to the NICU, to the neonatal intensive care unit, so that they can have continuous electrical monitoring there, basically, which is very, very helpful. And then there's some things to look out for. It's actually it's not all that common for us to have newborn babies who come in with some type of urgent heart problem, which is very good, and I'm very thankful for that. But some things to look out for would be difficulty breathing in a baby that isn't explained by something else.
Mm-hmm.
Episodes of altered mental status, again, not very common, but certainly if I hear that in a baby, I think about it.
Mm-hmm.
Pediatricians are very good at knowing what to look for, signs of potential illness or risk in babies.
Yeah. I like the term winning the game. That was a good, that's a coach that is a good way. It makes a ton of, again, it's something that we talk about a lot, is like just the awareness of knowing that you have disease, at any heart disease at any point in life, is putting you a step ahead and helping you, treat it. And like I said, I like calling that winning the game.
I don't remember when I adopted that, but I love that phrase. And I use it a lot I have an inherited arrhythmia clinic. So I see patients who are affected by genetic arrhythmia disease. And I love that phrase because I totally believe it. A lot of these conditions are very manageable with really good prognosis if you know that you have it. And if you are being managed by somebody who's pretty comfortable with the disease process, then we have excellent ways of managing, treating these disease processes and avoiding bad things from happening. And so if you know that you have it, you're winning the game.
Definitely. I love that. Okay. So I think you touched on this a little bit. So like, even for like parents, obviously I guess it's impossible to catch literally everything, but when a new parent, it's a very nerve-wracking and stressful time as it is. I know I've talked to, and my friends are getting to that age where they talk about how like you're in the hospital and all of a sudden you just leave with a baby, and it's, then you're kind of expected to, you learn. And I think it'd be good to kind of talk about some things maybe that, again, you touched on them a little bit, but if there's specific things parents should look for at home, and if they do see these things, should they call their pediatrician? Should they immediately call a cardiology office, and how they should handle that?
Yeah. I think about this a lot. I have a lot of these conversations with families. I have 2 little kids, as you know. And so, boy, I understand the totally different mindset of having a newborn at home. And, I worried about everything. And it's, you're taking care of the thing in this world that you love more than anything. And the thought of anything bad happening to that precious child is terrifying. And so I've experienced that myself a couple times, just being terrified by that. And I feel for people who are wondering about that. I know this doesn't directly answer the question you asked, but for a lot of the conditions I treat, I try to be very direct about the fact that this particular condition is not something that's life-threatening. Most of the things that I take care of fit into that box. That sure, there are these reasons that we monitor them and we manage them, but they're not sort of urgently life-threatening. And having gone through those thought processes myself as a parent, I really try to be direct about answering that question. And when there is a little bit of risk of a life-threatening arrhythmia, I'm very direct about that. And I say, here's what I think the risk is. This is what we can do about it. This is what we can't do about it. But having that open and honest discussion, I think really brings control to the conversation and allows parents, it essentially always results in relief and control and a plan. So some things to look out for. I think the biggest thing is family history that we can touch on. So there are a good number of kids out there who are affected by these genetic conditions, and often, unfortunately, they don't show signs or symptoms until a child has something dangerous happen to them. And I know, Mike, you're very familiar with this concept.
Sure.
And so family history is part of a pediatrician's visit. My kid's pediatrician, every single visit, he asks if there has been a change in my family history. And this is partly why he's asking that question, to know if there's something that he needs to think about in my children. So if there's a heart rhythm condition that could be genetic, it's important to bring that up at the pediatrician's office. And it's also important to bring that up at your cardiologist's office. There are some adult cardiologists who aren't, constantly thinking of family planning. And it's true that it comes up a little bit more easily when the mother is affected. If somebody's seeing a mother and the mother is pregnant, that pregnancy naturally comes into the conversation. And when a father is having a biological child, it doesn't always come up in that conversation. And so I think if a parent has a heart disease that they think has some chance of being genetic, I think it's important to ask that question. And then the other signs and symptoms are, like we sort of touched on before, breathing difficulty that you can't explain, color changes that you can't exchange, so a dusky gray color, a bluish color, altered mental status, the whole sort of eyes rolled back in the head for a period of time. We've seen that. Most of those, I think this is a very important point. Lots of babies have funny breathing patterns. That's a thing that babies do. Lots of babies have, they looked a little spaced out for a period of time, or they looked a little bit, babies get this skin modeling thing where they have this kind of lacy rash appearance on their skin. At the same time, we're careful with babies, and so we do. I think the most important thing is to bring this up with a pediatrician and ask the question. And pediatricians know that when you have especially a baby, when you have a small child at home, you're going to have questions, and they're very good at kindly, patiently, thoughtfully answering these questions.
Yeah. Totally. I know this is one point I wanted to talk about, and you touched on it, family history is a really important thing to understand. And you can correct me if I'm wrong, but I think it's always important to overshare and it be, nothing and rather than it be something. So I think the point is like if there's any sort of sign of, and I know this kind of goes to the quote unquote screening questions, but like a sudden death in the family before the age of 50, or an unexplained death to someone in the family, before the age of 50, to really be open and honest with your doctor about those questions.
Yep. Yep. And if they're not related, then, it's something that has taken 30 seconds to explain, and it's no problem at all.
Exactly.
Yeah, I agree. And how are you supposed to know as a, non-medically trained person, how are you supposed to know what's important and what's not? We're trained to know if those things that you bring up are important or not.
Exactly. So I just want to kind of, I guess, like go like a little later from like a newborn to now a parent has a child who started playing some like youth sports. And, as we get into like the teenage years, these sports start to become a little more competitive, and just talk about like what signs and symptoms that they should potentially keep an eye on, that could be a sign of a potential heart disease.
Yep. The biggest one by far is an episode of syncope or passing out during exertion. So exercise is the most common thing that we think of, but there also are other types of exertion as well. And so I actually have a number of patients who have played competitive sports their entire lives. And then the first presentation of something happening is an additional emotional response to it, whether it's winning a championship game, whether it's being late to an important game. These are situations that I've seen initially arrhythmias and very serious arrhythmias happen when you're exerting yourself physically, and then there's this additional, we call it a catecholaminergic surge, which basically means adrenaline that enters your body, and it's a additional exertion that leads to this arrhythmia. And so we see this in non-athletes. Some of the talk on our heart rhythm scene recently has been video games, for example, which aren't inherently dangerous, but the major rush that people can get when they're in the middle of an intense video game, or they just win an intense video game, something like that, can give you that same kind of basically exertion in your body that strenuous activity can give. And so episodes of dizziness to some extent, but passing out during exercise are things that should be taken seriously and things that should be evaluated. There certainly can be episodes of syncope during exercise that are not related to arrhythmias, but that's what we call red flags. So if a patient has an episode of syncope during physical activity, those we like to look into a little bit, usually with some heart rhythm monitoring. Chest pain with exercise, sometimes, much more commonly, that is not a dangerous thing, and it tends to be what we call musculoskeletal kind of chest pain. You can get cramps in your chest wall, you can get little sort of sprains in your chest wall. So usually that doesn't turn out to be a cardiac condition, but chest pain during exercise is something that I think should be brought up. I think something that symptoms during exercise that feel unusual to the patient, right? If you've got somebody who's been, playing sports their whole lives, and then they say, but this thing has happened that's felt weird, whether it's racing heartbeats, whether it's, no, I suddenly got dizzy the other day and I don't know why. I think those things should be looked into.
I think that's a great way to put it. Like just being an athlete growing up, I know when I think about like some of those heart disease symptoms that you mentioned, part of the issue for me was, and I don't think I displayed many of them, but I think the key is like feeling different about something, because when you say, everybody, like a shortness of breath, or I know you said a chest pain isn't but like those things to me when I was growing up was like, if I don't feel short of breath or I don't feel out of breath, then I'm not like pushing myself hard enough.
Yep.
So I think like that is like, um, the point you made of like something that's like out of the ordinary is something that needs to be talked about.
Yeah. Or I'm trying to think of the phrase that I usually use. I like asking somebody if they, if they think that they shouldn't have been so short of breath or something like that. Sometimes I get people in clinic who say, for what we call a chief complaint, meaning the reason they're coming into a clinic visit is shortness of breath with exercise. And then when you ask the patient themselves, they say, but of course I was, because I was just out with a viral illness for 2 weeks and hadn't exercised. And I wanted really, really much to get that same time on that sprint that I had before. So no, I didn't actually think it was that weird.
Yeah. Yeah, that makes
Yeah.
sense. I think
Yeah.
it's important, good point for athletes too. Because I know I've thought about that a lot. It's like, did I have these symptoms or was I just pushing myself or was it something,
Yeah, we've talked about that, trying to
Yeah.
suss out whether any
Yeah,
symptoms that you had before
definitely.
your arrest, were related.
Um, okay, so I think just talking about I guess is there like a sweet spot like age wise or I don't know if there's an exact answer to this, but where like some of these diseases that might not be necessarily caught at birth start to develop, or like is there an age where parents should really be like looking out for these things, or is it just kind of like is
Yeah.
no age? Should they always be on the lookout?
Yeah. It's a very interesting question because there are a couple ways that you can think about it. One is a population-based way to think about it, which is to say, when are these episodes, or when is this most likely to be dangerous? When are these episodes most likely to start coming up in people who are at risk? The answer to that tends to be around the early teenage years. And the reasons for that are multifactorial, like so many things in medicine are. One is growth. One is hormonal influence, which very clearly has shown to play a role in some of the inherited arrhythmia syndromes that I care for. Another is the type of competitive sport you're playing. And so a 14-year-old is probably going to be willing to exert herself or himself or themselves more than a 7-year-old is, and push themselves sort of beyond those limits. So for a number of reasons, age 12-ish is about when we would say, okay, we think that the population-based risk of these events goes up. It is more likely that we have a high school. I'll use an athlete, for example, although one of my points that I like to make is that it is not just athletes who are at risk for having these episodes. You've heard me say that to people so many times. But it's more likely to be a 16-year-old on a soccer field than a 7-year-old on the soccer field. But then there's also but this is my child we're thinking about, and my child we're thinking about. And so when you're actually thinking of very specific situations, the same, we give the same advice. If you have this kind of symptom, if you have this kind of family history, if you have this kind of concern, this kind of physical exam finding, then you need to be evaluated. And I see plenty of 5, 6, 7, 8-year-olds in my clinic for racing heartbeats or passing out or whatever else kind of symptom is appropriate.
Yeah, totally. I definitely had that in the back of my mind that I knew one of us was going to bring up that it's not just athletes, because I just
it probably was going to be me because some of my very favorite points.
It seems like a lot of these stories that you read and now this is very prevalent in the media. The stories are always about athletes. They tend to lean that way, and it's very important to note that it's not just athletes. So I appreciate you saying that.
Yeah, and along those lines, I mean, I could talk about this topic for forever, so I won't take enough time on this topic. Along those lines, there are pre-participation screenings that are done in many different ways, in many different locations. And there are a lot of reasons why they're done differently. And they primarily target athletes. A lot of people who, first of all, there's the there's the sort of less traditional athlete, right? Somebody who loves to come up with dance routines with a friend and is, lots of exertion there. Somebody who's playing really competitive basketball with friends on a weekend. The person who's playing video games really competitively. The person who has lots of exertion because they're fighting with a sibling. And so it definitely is not just athletes. And I will say that a major reason why the focus is on athletes, first, they are in general, again, population-based stuff, they are in general at higher risk than the people who are not participating in these athletic endeavors. But the other reason is that it's sort of a group of people that we have their attention. We have organized ways of screening them and, saying you can't participate unless you get this thing signed. And so it's a portion of the population that's pretty easy to focus on. And a lot of people who are fans of generalized screening say, okay, great, let's keep going with the athletes because this is a very, we have their attention, like I said. But a lot of people have an ultimate goal of providing the same kind of screening processes to all children.
Definitely. That's really important. And also, where do you cut the line of that?
Exactly. We could talk about this forever.
I know. I just my example that I always use is is someone in the marching band that's walking around with a very, very heavy instrument considered an athlete? I don't know, but they're doing a very strenuous thing. So anyway, I know we talked about, so if you could, I know there's a lot of different testing out there, but two of the more common ones that you mentioned before are an electrocardiogram or ECG and echocardiogram, or, just known as an echo. Could you just kind of talk about, what those two tests are, maybe what they entail?
Yeah, absolutely. I really like that we're talking about this question in particular, because I think this gets to what can we find in people and how can we find it? Because one of the points that you made quickly that I think we sort of moved over quickly, but is an extremely important point, is that there are a number of heart conditions that aren't identifiable by either modality, by an ECG or by an echocardiogram. So I'll take a step back. An ECG, or an electrocardiogram, is that strip of paper. It's usually red and white paper that people get when they put the 10 stickers on you. So they put stickers on your arms, your legs, and then they put 6 stickers across your chest. And it gives you a 10-second snapshot of what the electricity in your heart is doing. So we see electricity moving from the top chambers, where it usually starts, pausing somewhere in the middle to let the top chamber beat, and then it moves to the bottom chamber. And it shows us how a heart beats in sequence: top, bottom, reset, just like that. And it's only a 10-second point in time. And so it tells us during those 10 seconds what the electricity in someone's heart looks like. Now, there are certain things that at any moment an electrocardiogram looks abnormal. Things like most cases of Wolff-Parkinson-White, WPW, which is an abnormal extra electrical pathway in the heart that has the potential to be dangerous. That shows up on most people's baseline ECG. Somebody who has pretty notable hypertrophic cardiomyopathy will typically have an abnormal ECG at any point in time. But somebody has an anomalous coronary artery, meaning they have a coronary artery that's coming off of the wrong place in their heart. It's considered a structural heart disease. That person has a normal electrocardiogram at baseline. And it's when that person is exercising, stressing their heart, that coronary is basically pushed to its limit and can put that person at risk for dangerous heart rhythm problems. Or something called it's a very long name. It's called CPVT, or catecholaminergic polymorphic ventricular tachycardia. This is an inherited arrhythmia syndrome that has a normal baseline evaluation, but can begin to have arrhythmias that happen during physical or other kinds of exertion. And so we generally diagnose it with an exercise stress test, which requires a lot more resources. Certainly in a patient who has a concerning episode, yes, of course, we do an exercise stress test, but it's a lot more time consuming, costly than doing a 10-second ECG. And then an echocardiogram is a heart ultrasound. So this tells us the structure and the function of somebody's heart. It tells us if the heart is thicker than it should be, if it's more dilated than it should be, if there's a valve problem, if there's a hole in the heart. It tells us how well the heart is squeezing. So we would call the function of the heart that way. And that can answer nearly all of the structural heart questions. Occasionally you need additional imaging like an MRI to really come up with some of the details, but that answers most of those questions. But you can't see the electricity on an echocardiogram. So most of the patients that I see in my heart rhythm clinic have a normal echocardiogram, even if they have some risk for arrhythmia. And so the type of screening that we do depends on what it is we're looking for. If I'm looking for, if somebody has a murmur and I think that they might have a valve problem, we do an echocardiogram, usually an ECG also. But if somebody has syncope or fainting during high level of exertion, we will usually do an echocardiogram because we're looking specifically for hypertrophic cardiomyopathy, meaning thickening of the heart muscle that's not normal, or an abnormal coronary, like that thing that I mentioned. But a lot of our workup is going to be an electrical workup. So we're going to start with an ECG, an electrocardiogram. And if that's normal, we're going to consider doing other things too, like an exercise stress test or longer term heart rhythm monitoring, something like that.
That makes sense. Okay, so our kids getting these, well, we know that the kids are not getting these tests at their annual physicals. So that's the answer to the question. I don't even need to ask it to you.
That's the answer.
Yeah, I don't need to. So we know, I guess, what are your thoughts on a parent, just taking their kid to their pediatrician and talking about those two tests? Is it something that they should talk to their pediatrician about, ask for, or is it something more where they should maybe wait to ask? I don't know. How do you think parents should handle that conversation with their pediatrician?
Yeah, that's a really tough question.
Yeah.
So the echocardiogram is easier. If there's I think there, in nearly all situations, there should be a pretty good indication to have an echocardiogram or the heart ultrasound. So if there's something on the exam, if your pediatrician hears a murmur, for example, or if there's a symptom, or if there's if a person's biological parent has hypertrophic cardiomyopathy, for example, that person should have a screening echocardiogram. But if there isn't a reason like that, then almost nobody would say, oh, yes, we should do a screening echocardiogram. In rare instances, usually part of research studies, honestly, there are screening echocardiograms that are done. But honestly, there just are not nearly resources enough to use this test wisely for that purpose. And at least with the information that we know now, I also personally don't believe that that identifies enough patients. And basically, I don't think that it's at all likely to help people out if there isn't anything else that comes up that's concerning. And so that's how I feel about that one. The ECG is a really hard question. I am a fan of screening ECGs. You know this.
Yeah.
There's a lot of talk in our pediatric heart rhythm community about how we feel about this. Most people feel that it's helpful. And we know, I mean, we have many examples of how this can prevent bad things from happening. This can save lives. And the resources spent, the cost of an ECG is not that much compared to a lot of other things that we do. It becomes a lot more complicated in thinking about doing these for, every child. Is who's going to read that number of ECGs. And we know that the quality of the read depends on who reads it. Those of us who read many ECGs are best suited to do it, but there aren't really that many of us who
Makes sense.
who are trained that way to do it. And the number of abnormals that are appropriately identified and the number of normals that are appropriately identified, which is also important because we can't go doing exercise stress tests for half the people that we get ECGs for. And so we need to, as appropriately as we can, identify abnormal and normal. We know that gets a lot muddier when you have people who are less familiar and less experienced with reading ECGs. There are more and more places are doing it and trying to find ways that we can do this successfully. I think one of the cool things, again, we could talk about this topic for forever, but is artificial intelligence has come up on the scene as a way to do this successfully. It starts with identifying a particular heart condition. You could feed tons of ECGs into a system and have it look for one specific, signal for one specific kind of heart disease. But I think eventually that's how we're going to be able to actually do this on a grander scale.
Makes sense. I know it's a tough question, so it's just but so I appreciate it. So I just want to, before we finish, just talk a little bit about kind of like, now you've diagnosed maybe like a 14-year-old person with heart disease. And this is like really important to me because I think a lot of times maybe fear for saying like how you feel is the fear of like having part of your life taken away from you if something is theirs. And so it's like really important to me I think people understand, and this is my personal opinion, that once you are diagnosed with heart disease, you can have like a really normal life. And kind of just talk about that process. Like you've realized you have a child that has a heart disease. Now you're working with his family to help that child, have a good quality of life, but also be safe.
Yep. Yeah, that is one of my passions. I'm also I'm an exercise proponent. I'm a sports proponent. Athletics have been something I've been interested in my whole life. And so I also try to be very direct about that question because I know that that is forefront of people's minds. And often people are afraid to ask me that question because you're right, Mike, they don't want to know the answer. And so I bring it up whenever I can to have that direct conversation. It's a very common situation is that a parent and child come in to see me. The parent says, what do I need to do to keep my child safe? And the child says, all I care about is, in my most recent example, is playing basketball. That's all I care about. I need to be able to play basketball. And over time, we've recognized that allowing children and adolescents to participate in the activities that they love is vital to physical health and emotional health. Thankfully, the mental health of our population has become a topic that we're talking about more because it is so important. And taking sports and other physical activities away is, I think, often the wrong move. So I do whatever I can to allow patients to be able to play. So we have the conversation, we come up with safety plans. As a whole, our field is moving towards allowing people to be able to play. So 20 years ago, people would say, you have long QT syndrome, you can't exercise. And now that's really, really
Yeah.
shifted. And we found that if you are managed appropriately, if you take the medicines that you're supposed to take, if you follow this plan, the rate of dangerous events happening is tiny, 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 tiny in that population. And so it's just not a good idea to say by default, you can't play. There are a couple of diseases in particular where exercise restriction is part of most people's plans, and there's not a great way around it. Sometimes it's restriction, it's limitation, but not total restriction. And so I try to be very clear about that too. Sometimes I say, okay, for this particular disease process, you can't be playing 3 hours of intense soccer every single day, but I can let you play a few days a week, because over time, what matters is your total burden of exercise and the effect that that has on your heart. And in other conditions, it's at any given moment, this can put you at some risk. So what's your safety plan? And so I think if anybody ends up in this position and your medical provider isn't very direct with you, please ask the question. In most circumstances, you're not going to be too disappointed with the answer, I think.
Cool. That makes a lot of sense. So one question that just came in is, can you just talk about some of those conditions really quickly, and which ones could put you at higher risk for a potential, sudden cardiac arrest or life-threatening moment?
Yeah, absolutely. So the most common example that I see in my heart rhythm clinic is something called long QT syndrome. So there are a number of genetic mutations that can prolong the reset time of the heart, which then can put people at risk for having dangerous arrhythmias. Each type of long QT syndrome, so the specific gene that is abnormal, can put you at a higher risk or a lower risk of something happening during exercise. It's very unusual for me to restrict those patients from exercise now, because we have really good data showing that in essentially all types of long QT syndrome, you're safe as long as you're following your medical plan. There, of course, are individual examples that don't fit this. And so this conversation has to be individualized with the medical person that you're seeing. But I'll say, so often in those situations, I'll say, okay, I'm fine with you doing pretty much everything you said, but I don't love you swimming in deep, dark water by yourself. And so I don't love the idea of you doing a triathlon in an ocean sometime, because although the risk of something happening to you is so small, you're in the middle of deep, dark water if something happens, and it's hard for someone to save you. Whereas if you're a high school swimmer, go for it. There's people watching. There are often AEDs in these locations. And so we can come up with a safety plan that I like for you. And so I individualize these conversations to how much the patient wants to do a particular activity, and what they want. So that's long QT syndrome, which is a very common disease that I see and I manage. Things like an abnormal coronary artery. So I've mentioned that a couple times. The cure for that is surgery. There also can be abnormal coronary arteries that don't need to be repaired. So I don't just want to give that as the umbrella thing, but a specific type of coronary artery anomaly, if your provider determines that it should be fixed, surgical repair is in almost all circumstances curative for that. And so you can play after you have that surgically repaired and recover from it in most cases. The one disease, so I mentioned that in one disease, I limit but don't totally restrict activity. That's something called arrhythmogenic cardiomyopathy. There's a kind of heart muscle stress your heart and can lead to more scarring and initiation of arrhythmias. And so what's been found to be important in those patients is limiting your total burden of high intensity aerobic exercise over time. So we'll limit it to a certain, period of time doing each particular activity. And I cater, that's a very, very individualized conversation that I cater to people. There are a number of other disease processes that I manage. I'd be perfectly happy to talk through one specifically if somebody wants.
Yeah, let's see if.
Thanks. Yeah, I'm not really paying attention to the chat.
No, I have it here. Yeah. No, so I think I mean that's those. Unless anyone has any other questions that come in there, I know you have. I think you have some patients you have to see too. So no, so I just want to, like, in closing, and I'll give you an opportunity to add anything you want to add, but just say thank you, because I think this is so beneficial. And I'll, specifically some of the people that, like, I work with, when we were talking about this, and they're actually their moms, and they said, like, this is just going to be so helpful for me just to kind of learn. And like, I just think it starts with what we talked about at the beginning of the conversation of, like, heart disease does affect young people. And just like having that conversation, I think is so important, because I know in my life, my parents didn't think it did. And they had that same exact conversation with, it was another doctor, but the same thing of, like, I can't believe that my young, healthy, athletic son could possibly have something wrong with his heart, because look at him. And it was just such a lack of awareness by us as a family. And so just like having this conversation of, like, that these things do exist, and hearing, how, the different ages of the patients that you treat, things for parents to look out for, it's just so invaluable. And just another way you are having a huge impact on so many people. So I appreciate it. Thank you so much. And like I said, we've worked together closely in a lot of different ways, and I see the impact that you have, and this is just another way, and that's going to happen. So thank you.
Yes. It's funny. I'll meet somebody through one of my kids, and they ask what I do, and pretty often people say, "Really, that possibly could happen in kids?
How is that a job?"
And children. Yeah. And yeah, I mean, thank you, Mike. The role that you play in a lot of this is enormous. I'm clinically busy in my job, and I wish that I personally, and I know members of my team wish that we were better able to interact with the community and sort of provide some of this guidance that we think is important. And as you know, prevention of life-threatening episodes is something I care very much about. And so I want to do what I can for it, but I could not do it if I didn't have people helping me to do this, helping me reach people, right? The research that we do doesn't really matter that much if it doesn't actually reach patients and help make lives better and longer. So yes, as always, I'm always telling you that I'm grateful for you. Thank you.
Yeah, no, thank you so much. And yeah, so that's pretty much it. I mean, just as a reminder to everybody, we will this has been recorded, so we will edit. Well, not that we have to edit, we'll just put like a little intro and closing into it, and add it to our YouTube channel. So we'll send out that link. And thank you everybody for joining, and thank you again, Dr. Beach, for being here with us.
You got it. Thanks,
Have
Mike.
a great day, everybody.
Thanks, everybody.
Bye-bye.
Bye.